Good afternoon, class. In this recording, we're going to be looking at therapies relating to renal failure. And specifically, we're going to look at some examples of drug therapy, nephrotoxic substances, renal replacement therapies, and kidney transplants. Some common examples of drug therapy used in clients that have renal failure are cardiac glycosides, vitamins and minerals, synthetic erythropoietin, and phosphate binders. The cardiac glycosides are used when heart failure induces kidney failure or disease and makes it worse. Some examples of cardiac glycosides include digoxin, nova-digoxin, different forms of digoxin basically. And you know, with digoxin we always want to take a pulse before we administer it. If the pulse is below 60, then we want to hold it. We need to instruct our patients on how to do that as well if they're on that at home. They also need to notify their healthcare provider if they have problems with their vision relative to color vision, blurred vision, if they notice their eyes are more sensitive to light, if they're seeing light flashes, and halos around bright lights. We also need to teach our patients taking digoxin not to take antacids within 2 hours of the drug. And you know, the drug slows the heart rate down and can cause severe bradycardia. That's the rationale behind checking the pulse. Good afternoon, class. In this recording, we're going to be looking at therapies related to renal failure. We're specifically going to look at some common examples of drug therapy, nephrotoxic substances, renal replacement therapies, and kidney transplants. Common drugs used with kidney failure include cardiac glycosides, vitamins and minerals, synthetic erythropoietin, and phosphate binders. You'll recall that cardiac glycosides are used to slow the heart rate down and make it beat more forcefully. We use the lanoxin when the heart. Good afternoon, class. In this recording, we're going to be looking at therapies related to renal failure. We're going to focus on common examples of drug therapy. We're going to look at nephrotoxic substances, renal replacement therapies, and kidney transplants in this recording. Shown here are some common classes of drugs that we administer to patients that have kidney problems. Cardiac glycosides are used when when there's heart failure that induces kidney injury or disease or makes it worse. An example of a cardiac glycoside is digoxin. And you'll recall that with digoxin we take the pulse before administering it. If the pulse is below 60, we notify the healthcare provider. Lanoxin slows the heart rate and can cause severe bradycardia. We also want to monitor for signs and symptoms of drug toxicity that require that the dosage be changed or the drug to be stopped. Some signs and symptoms of toxicity include changes in color vision, blurred vision, eyes sensitive to light, light flashes or halos around bright eyes, changes in behavior, mood, and mental ability, chest pain, and palpitations. So we want to teach our patients to monitor for those types of things or teach their family members. Teach our patients also not to take antacids within 2 hours because they prevent absorption of the drug and may delay or inhibit the drug's effectiveness. There's a wide variety of vitamins and minerals that are prescribed for these clients, particularly folic acid and ferrous sulfate. So these drugs are administered quite commonly to these clients. And you need to be familiar with how to administer these drugs and their effects on whether you should take them before or after dialysis. So I'd encourage you to read up on vitamins and minerals such as folic acid and ferrous sulfate. Synthetic erythropoietin, or Epigen is a common form of this drug that we give. It prevents anemia by stimulating the red blood cell growth and maturation in the bone marrow. This drug can induce serious cardiovascular problems such as myocardial infarction. We want to teach our patients to report any side effects that they may experience, such as chest pain, difficulty breathing, high blood pressure, rapid weight gain, seizures, skin rash, swelling of feet and ankles if they're taking this. And reinforce that they must have their hemoglobin levels monitored weekly if they're on this drug. The drug can raise the hemoglobin hematocrit to the point that the blood viscosity increases, raising the blood pressure and increasing the risk of MI. Phosphate binders are also administered. High blood phosphate levels cause hypocalcemia. Drugs lower serum phosphate levels by binding with the phosphorus present in food, and so we want to lower the phosphorus so that the calcium can get up to a good level. These drugs should be taken with meals, and if they're taking digoxin as well, they need to be separated by 2 hours. So these are some common drugs we see administered. Some drugs that can lead to problems with the kidneys, so nephrotoxic substances, antibiotics. Certain antibiotics are known to lead to kidney problems and kidney failure. Aminoglycoside antibiotics are particularly known for causing damage to the kidneys. Chemotherapy is quite difficult on the kidneys as well. Commonly taken non-steroidal anti-inflammatory drugs also can lead to kidney problems. Tylenol, particularly overdose of Tylenol, can lead to kidney problems. And with metformin, you don't want to administer metformin within so many hours of any radioactive dye, or you're going to potentiate the effects on the kidney. Radioactive dyes can cause kidney damage as well. Certain chemicals and heavy metals also have been known to damage the kidneys. So anybody that perhaps already has some problems needs to avoid these nephrotoxic substances, because that's just going to compound their chances of acute kidney injury or chronic renal injury. If we do have to administer some of these drugs, then being very careful to monitor the kidney function and monitoring drug levels as well will help to prevent if we monitor the drug levels, then we can adjust the dosages to get the best fit for that patient for the dose of medicine compared with the risk associated with the patient taking it. Now we're going to talk about renal replacement therapies. There's a couple of different types of renal replacement therapies. There's peritoneal dialysis, there's hemodialysis, and there's continuous renal replacement therapy. The goals for renal replacement therapy are to remove the end products of protein metabolism from the blood and maintain safe concentrations of electrolytes, correct acid-base imbalances, and remove excess fluid from the blood. So the first type of therapy we're going to talk about is peritoneal dialysis. Peritoneal dialysis uses the patient's own peritoneum as a semi-permeable dialyzing membrane. Fluid is instilled into the peritoneal cavity, and waste products are pulled into the fluid, and then the fluid is drained from the peritoneal cavity. This is achieved through an access catheter that's placed into the peritoneal cavity. This may be a temporary catheter inserted through the abdominal wall, or a permanent catheter tunneled in. The catheter most commonly used or tunneled is called a Tinkoff catheter. There are some advantages of peritoneal dialysis over hemodialysis. We see less anemia, reduced cost of equipment, the patient has fewer dietary and fluid limitations. The patient does it at home, so it's an independent type of dialysis. And it does closely resemble normal kidney function as compared to the hemodialysis. The disadvantages: there's risk for peritonitis. The patients may have elevated serum lipids, and the body image may be disturbed. But the body image is going to be disturbed anyway. It doesn't really matter which way you do it. Patients cannot use peritoneal dialysis if they've had recent abdominal surgery or have a lot of abdominal trauma or scarring. There are several different processes that can be used with peritoneal dialysis. I just listed a couple. The continuous ambulatory peritoneal dialysis. There's continuous cyclic peritoneal dialysis. I'll give you an example of my mother. My mother was on dialysis, peritoneal dialysis, and she actually did the manual infusion like pictured here a couple of times a day, and then she actually hooked herself up to a cycler at night for 12 hours. And so sometimes there's a combination of processes used. With the daytime dialysis, there's 3 phases. They inflow the diacylate fluid, which is a concentration of electrolytes into the peritoneal space, and that's termed inflow. Inflow allows about 2 liters of fluid to go into the cavity over 10 minutes, and then they let that dwell in there. Dwell time is when the fluid remains in the cavity, and then it's drained out over 20 to 30 minutes, and then that bottom bag is discarded. And the continuous cycler, they just hook themselves up to a little machine at night. Key with peritoneal dialysis is maintaining the sterility of connections when you're hooking up and discarding. The patient has to wear a mask. The patient should wear sterile gloves. It's a sterile procedure. And all fans need to be turned off, because you don't want any bacteria getting into that catheter, because they will develop peritonitis if that happens. So peritonitis is a most frequent and biggest concern for complications. They can also get an infection at the catheter site. Some other things that the patients typically experience, side effects or whatever you want to call it, they complain of a constant sweet taste in their mouth, anorexia. They can develop hernias, and altered body image is another problem, and low back pain. They may have pain at the site, and they may have some problems getting the dialysate to actually infuse into them sometimes. Nursing care centers around education and support. If you have a patient that's in the hospital having this done, or you're caring for someone somewhere else, you want to monitor their vital signs, their weight, and they should be taught to monitor their weight as well, and their lab values. Again, strict surgical asepsis is really important, and just observe make sure it flows back out. It should be cloudy when it flows back out. I'm going to double check that. I think it should be cloudy. If the diacylate that comes out, or the effluent is what it's called, if it is cloudy, that is an indication that they possibly have peritonitis. So that would be an indication of infection. It's the earliest sign of peritonitis is a cloudy or opaque effluent solution, and so we wouldn't really want it to be cloudy. Hemodialysis is the next type of renal replacement therapy. Blood is pulled from the patient through a system which includes a dialyzer, diacylate, and usually a heparin delivery system. The blood is cleansed and filtered and returned to the patient. This type of dialysis requires a vascular access device. This can be in the form of a special subclavian catheter, which is a temporary catheter, or a permanent graft or fistula. A large needle is inserted into the graft or fistula, and so you see I've got a couple of pictures here. This is an example of a fistula, and this is a AV graft here. Kind of looks like a horseshoe. Advantages of hemodialysis is it's very useful in emergencies. It allows rapid removal of waste, electrolytes, and fluid. Disadvantages is you've got to have these vascular access devices, and the patient has to take anticoagulants, so there's a potential for hemorrhage, anemia, rapid shifts in fluids and electrolytes, muscle cramping, nausea, vomiting, and air embolism. The leading cause of death after hemodialysis are strokes and MIs, followed by infections, and so those are your primary complications you're worried about. If you have a client that has an access device, if it's a fistula or AV graft, you want to assess the graft for what's called a thrill or a bruit. A thrill is a rippling sensation caused by movement of blood through the pathway, and a bruit is a swooshing sound that you can hear with the stethoscope over the site with every heartbeat. That tells you that that device is working if you feel or hear those two things. Obviously, you want to assess circulation on the extremity. You want to put up a sign saying no sticks or injections on the site where the graft or fistula is located. Typically it is located there in the arms. So you don't want anything to happen to that arm to injure that arm or bother that graft. So there should be no sticks or IV fluids or blood pressures or finger sticks on that side of the body. Sometimes if they do have some complications relative to the heparin, such as bleeding, they may ooze from their site where they've been stuck, or they may have some swelling in their extremity. That is a complication, and typically we would administer protamine sulfate if they're having problems with bleeding from the heparin to counteract that. Other problems related to the access device include thrombosis or stenosis or clotting at the shunt where it clots off and then it can't be used. And there are some strategies to manage that if that occurs as well. An aneurysm formation is another complication with the access device. Typically the clients go for their hemodialysis to the dialysis center, an outpatient setting. There are some places, I believe, that actually train the patients and they do the dialysis at home, but around here most of the patients go 3 times a week to the dialysis center, and they're on the dialyzer for roughly 3 to 4 hours each time they go. So if you have a client that's in the hospital and they usually take dialysis, then they will go and have their dialysis while they're in the hospital there in the dialysis department. And you've got to realize some drugs are actually removed during dialysis, so you wouldn't want to administer certain drugs before they go and have their dialysis. And there's certain drugs that are contraindicated if they're about to go have their dialysis as well. So some examples of some of those drugs: the vasoactive drugs that should not be given because they can lead to problems before they have dialysis are certain antidysrhythmics, certain antihypertensives such as beta blockers and ACE inhibitors, certain vasodilators such as nitroglycerin, hydralazine, and nitroprusside. Other drugs that are going to be lost with the dialysis include the aminoglycosides, antivirals, penicillins, anticonvulsants, cephalosporins, anti-TB medicines, and so forth. So coordinate with a physician and determine the best drug regimen and determine which drugs should be held or given prior to the treatment. Realize that these clients are going to be on heparin, so they may have some problems with bleeding. So you want to monitor the PTT. Post-dialysis assessment, you want to monitor for hypotension. That is a very common post-dialysis problem. Sometimes they take too much of the fluid off too quickly, and they have some syncope, and so they're at risk for falling. And if their blood pressure is low enough, you may have to rehydrate them. Another problem is disequilibrium syndrome. It's caused by a rapid decrease in that volume in BUN. Changes in the urea level can cause cerebral edema and increased intracranial pressure, resulting in headache, nausea, vomiting, restlessness, decreased level of consciousness, seizures, coma, and even death. And so a disequilibrium syndrome is something you should be monitoring for after hemodialysis and treat accordingly. Infections can occur as a result of hemodialysis. It used to be more common when blood was not screened as closely and when we didn't have erythropoietin. These folks had to get a lot of blood transfusions when we didn't have erythropoietin. And so nowadays we don't see as many infections, but because the blood's safer to give them and we're not having to give as much blood, but also there's strict guidelines relative to cleaning the dialysis machine. And so we've got standard precautions also. So we're not seeing as many infections associated with hemodialysis as we used to. The patients may have muscle cramps as a result of the shifts in the electrolyte balances and changes there as well. This shows you just a little drawing of continuous renal replacement therapy. It's an option for patients that have acute renal failure. A cannula is placed in an artery and a vein or two veins, and the cannula is connected to tubing that contains a filter and a collection device. The patient's blood flows through the tubing, and excess fluids, electrolytes, and waste are filtered into the collection device. The blood is then returned. This procedure does not require diacylate and has little effect on the cardiovascular stability and is continuous. It can be used alone or in combination with hemodialysis. So we see this used quite often in the critical care areas. The next thing we're going to talk about are kidney transplants. Candidates for transplantation must be free of medical problems that might increase the risk from the procedure. Candidates are accepted for transplant up to 70 years old. And an individual basis they're evaluated on an individual basis. They're thoroughly assessed, and there are certain guidelines that are used to determine who's a candidate and who's not. Patients that have conditions that preclude kidney transplant include metastatic cancer patients, chronic infections, severe psychosocial problems such as alcoholism and chemical dependency. Long-standing pulmonary disease increases the risk for complications and death, so sometimes they're not a candidate as well. The donor may be a living donor, or a non-heart beating donor, or a cadaver donor. The availability of kidneys is very limited, and to actually donate a kidney from a live donor, they must be 18 years old and free of any type of systematic disease or infection, have no history of cancer or renal disease, and have a normal functioning kidney without any problems. Conventional approach for kidney donation: the patient is hospitalized 4 to 7 days and can return to work in 6 to 8 weeks. The donor is hospitalized 2 to 4 days and can return to work in 4 to 6 weeks. They will take a laparoscopic approach if possible from the donor, but a conventional approach for the recipient. If the kidney fails, then the client is obviously very disappointed. Pre-op care for the recipient, just the basic pre-op care. Sometimes they need to see a psychiatrist if awaiting someone else's organs or feeling guilty about taking a living donor's organs, or if they have to take a recipient that's died. A lot of medical workup has to be conducted, even psychiatric and dental workup for both the recipient and the donor. Immunosuppressant drugs are begun on the recipient, and the recipient may also be given a transfusion of the donor's blood, as this tends to decrease rejection. Post-op care. Usually general post-op care is what's provided. The patient will have an indwelling catheter, and urine will be bloody but will gradually clear. You want to maintain catheter patency. If the patient is oliguric, they may be treated with diuretics. Some have to have dialysis a few more times before their kidney will actually start to work. Some people's grafted kidney begins to work immediately. Some patients have fluid depletion due to massive fluid loss after surgery. You want to watch for signs and symptoms of infection, and teach them signs and symptoms of infection and signs and symptoms of rejection. You want to teach the patient to take their medications exactly as prescribed, to report adverse effects or reactions, to follow the diet that's prescribed, to avoid anybody that has an active infection. And their activity will gradually increase as prescribed by their health care provider. Post-op care, you will monitor fluid intake, urine output, you'll monitor their weight. And I failed to say this with dialysis, but you will weigh the patient with dialysis before and after. And that's how you know if you took off fluid and how much fluid you took off. And that's just a good judge of how your patient's doing. with the dialysis. So weighing the patient's very important for this, as well as people that are on dialysis. For post-renal transplant, though, again, you want to your nursing interventions were geared toward impaired urinary elimination, deficit fluid volume, risk for infection, and ineffective management of therapeutic regimen and anxiety. So with the impaired urinary, they'll have a catheter for a week, so you want to monitor intake and output, and you should see increasing urine output, a normal blood pressure, and decreasing BUN and creatinine, and a stable weight. Typically, we will monitor urine output every hour times 48 hours immediately after a transplant. For the fluid, you want to monitor their IV fluid therapy closely, manage their INO. For risk for infection, they're going to be on immunosuppressant drugs, so resistance to infection is diminished. You want to monitor for any slight hint of an infection, such as fever, elevated white count, cough, any kind of drainage. Good hand washing is a very much of the essence important with these patients. Complications are listed here. There are many different complications that can happen post-operatively. The main one we're really worried about is rejection. And it can occur hyperacute within 48 hours, and so you see some of the symptoms there, and the organ has to be removed to decrease the signs and symptoms. It can be an acute rejection where it can be a little bit later, and then it can be a chronic kind of thing that the patient rejects the kidney. So I encourage you, as you prepare for the next exam, that you review closely signs and symptoms of rejection and your complications. Read up on these complications. Thank you very much. This concludes this recording.